Thanks very much to the organisers, and I will note that apart from the earlier start, we've also managed to avoid the Australian Open final, Chinese New Year. It's a crowded time of year, and the other change is that I'm now speaking before Ian Barr, which is it's always been intimidating speaking after him. So I'm going to talk about COVID and COVID variants, and as you all know, that the SARS-2 virus has continued to evolve over time. You can look at it in terms of genetics or antigenic mapping, and I'll come back to this in a moment. Stan Perlman has helpfully explained the system of TAG-VE and the TAG-CoVac assessments, but just to say that there are risk assessments that are published frequently, and they look at the growth characteristics, immune characteristics, evasion characteristics, and clinical characteristics in terms of all the new variants under investigation. And this translates to the TAG-CoVac statements where recommendations are made. This system probably isn't quite as mature as it is for influenza, but obviously we've only had this for a few years versus the 50 or 60 years that we've had of the influenza system. And then these translate into different vaccines being made by different companies. This is just the Pfizer vaccine, but obviously Moderna and other vaccine manufacturers as well update their vaccines regularly as well. So what I'm going to do in this talk is just to talk through the considerations that TAG-CoVac go through, and then just view that with through an Australian lens. So looking at genetic evolution, the way that antigens are characterised, the immunogenicity data, and vaccine effectiveness, and then they also consider vaccine development plans. So globally, obviously the last 12 months has really been dominated by these two variants, XFG and NV181. But when you look at Australia, although those variants still dominate, there are other variants around. So what's seen globally isn't always exactly what's seen in Australia. The way that this is characterised using phenotypic assays is quite interesting. It's based on cartography. So if you imagine 3 mountain peaks that you can see, and then you're noting your distance from and direction from each of those, you can triangulate where you are in space, and that, I guess, is the principle of GPS. And so this is done with serum, where how distant is the serum, reference serum from different variants. And just to note here, what you can see is a lot of the recent variants are actually quite closely clustered together. So XEC and one, I don't think you can quite see that there, but some of the more recent ones are in that little cluster at the top. It is different whether the mouse has been vaccinated or whether it's their first vaccination. And what you can also see is XBB 1.5, which was the dominant variant in 2024, is actually quite distant from that. So just keep that in mind when you come to see the next few slides. And then just noting the originals, Wuhan strain is way off into the distance compared to where we are now. So what you can see here is this is UK HSA data, and this is the next two slides are from the spring and then the autumn. So spring being early in 2025 in the UK. What you can see here is that this evidence of protection early on, so a vaccine effectiveness of sort of around 40-50% early on, and then that falls over sort of 20 to 30 weeks, so that effect is not apparent, at least statistically. And these are usually using fairly large study sizes. So if you can't see a benefit in that, it probably isn't there. And so this is when the vaccine in the UK that was being used was XBB 1.5 and JN1 was circulating, so quite a mismatch. But what you can still see is even despite that mismatch, there is an increment in vaccine effectiveness, albeit relatively short term. In contrast, the autumn season, so where they were using JN1 and XFG and 181 were circulating, and those were the strains that are relatively tightly clustered. You can see that vaccine Effectiveness does increment and does seem to be persistent, although obviously there hasn't been quite as much time since the autumn dose, at least in these data. In the US, there have been a number of studies looking at the linked electronic health record systems, so the VISION and IVY studies, and they're both studies of vaccine effectiveness against hospitalisation in those over the age of 65 years. And what they found was fairly consistent across the different studies. In the immunocompetent people, there was a protection of between 40 and 50%, and then a little bit on the lower side with immunocompromised patients. So again, of a similar magnitude to what we saw in the UK. And then in the veteran study, they looked at vaccine effectiveness against different endpoints. And what you can see here is that the vaccine protection against relatively milder disease, so ED visit, was not as strong as against hospitalisation, and it was much stronger against death. And on the right there is the different, there's a forest plot with the different subgroups of people, and you can see that it is fairly consistent across all the different groups of people there. We've looked at this in FluCan. So in the top half is vaccine effectiveness against hospitalisation in those over 65 by when if they'd received a vaccine in the last 12 months. And then in the bottom half is those that had received it in the last 6 months. And you can see that if you received a vaccine in the last 6 months, vaccine effectiveness was a little stronger. So this is the odds ratio. So the vaccine effectiveness would be in the order of sort of 35% here. And not quite as strong in those that had received it in the last 12 months. This is the older group. You can also see that in 2022, vaccine effectiveness wasn't strong. And I think one possible explanation for that is that there was very widespread circulation of virus. And so a lot of the control group would have been infected and therefore also protected, and therefore probably had a similar effect size as vaccination there. And then looking at time since vaccination, you can see that there's evidence of waning effect, and the bottom half in those over the age of 75, you can see that at least within the first 3 months, there's strong evidence of a vaccine effect. And in this smaller study, it's a bit difficult to tell after that time. So what's the future? So in December 2025, the TACOVAC recommended LP 8.1. Most of this, noting that all of these circulating variants are so tightly clustered, so it probably doesn't make a huge amount of difference, but it does look like it's very slightly better than the last JN1 vaccine. But they did note a lot of evidence gaps for this. But what has seemed to have emerged in the last weeks of 2025 is this new variant, and you can see that just creeping up at the bottom there, BA3.2. So starting to early signs, perhaps, that it's starting to emerge. And just to recall that this one is one of those strains that is quite different. So, and there is this delay. So at the top is the recommendations. The middle panel is the circulating strains, and the bottom one is where the vaccines have been approved. And you can see, for example, so XBB 1.5 is an example, had been circulating for about half a year before the TACOVAC made the recommendation. And then there's another bit of a delay between that and when the vaccine was approved, so that it really is quite at the tail end of the XBB season. It hasn't been quite so important for JN1 and its subvariants because those are relatively antigenic matched, but there still is this ongoing delay. So the current variants that we have on this antibody map is you can see so this is the current cluster of 8.1, but you can see that BA3.2 is quite removed from that, which is of some concern if this does emerge. And this is borne out by neutralisation studies, which show that the binding to BA3.2 is relatively low compared to the other subvariants out there. So the current recommendations are at present unchanged, so we still recommend every 6 months for the, people over the age of 75 years, recommended for those between 65 and 74 years, but they're eligible to get more frequent vaccine, and then for younger people, they're eligible for a dose every 12 months except for the immunocompromised. So to summarise, JN1 and those so that group of subvariants are the most common, and this includes LP8.1, which is the next variant vaccine coming out. There are immunogenicity studies which suggest that it is well matched, except for BA3.2, which is emerging. Vaccine effectiveness studies do suggest continued moderate effectiveness against COVID hospitalisation. And it probably is that if it's not well matched, there's a shorter duration of protection than where it is well matched. But there is some increment in protection, and that's still worth having. So the next vaccine recommended is LP8.1, and this is probably slightly better against some of the current subvariants than the JN1 variant, but this BA3.2 is now reported. Very early days, but there are signs that it's emerging, at least in some jurisdictions in Australia, and this does look antigenically distinct. But probably important to note that there are no findings suggestive of that this is associated with increased severity of disease. So I'm going to leave it there, and just to thank Hannah Morgan, who's working with me, and Alicia Arnott and Betty Liu for their help.
Thank you very much, Alan. And we are back on time, and there is time for a question. John?
John Litt, retired academic GP and public health physician. Interesting talk, Alan. You, the elephant in the room, nasal viral options, and also in terms of oral agents. There was an interesting randomised trial by the Germans on azolastine, which is used in the GP land for sort of sinus infection, which is available across the counter. It was double blind, but the confidence was very wide, but it was about a 57% reduction in the likelihood of actually getting COVID. So those two other avenues, you focus very much on vaccines, and that's been terrific. But in the GP land, people say, how can I prevent getting infection? And we've had a lot of discussion about the nasal one, and I realise it's fraught. But some people are starting to look at other agents, in terms of the respiratory passage to try and reduce that risk. Can you make any comments on that?
Yeah, look, I'm not familiar with that trial specifically. I'd be very interested in those details. But I think it is always difficult to have, except in perhaps very highly motivated and highly selected populations, I think it is much more difficult to have something that is taken regularly as opposed to one-off dose of a vaccine, every 6 months or every 12 months. I mean, oseltamivir works very well as a preventative, but there's no chance that we're going to be giving that broadly as a public health intervention. But it's certainly for very selected populations, to prevent the spread of outbreaks in aged care. I think a preventative agent would really be quite useful.
Or doctors getting on a plane and going to a conference.
That too. Yeah.
One more question, Paul.
Alan, thank you for the talk. And I'm not sure you can answer this, but is there any potential for the facility at Dandenong to produce an Australia-specific vaccine if we're showing something that isn't similar to what was recommended 6 months ago?
Yeah, that's really interesting. We don't have a AIVC for COVID, and so I think the governance would need to be in place. I think, in theory, Moderna could do it for this is the Clayton facility, and with a very short turnaround, just changing the sequence around, and they're obviously collecting a lot of these sequences anyway. But I think it would need a governance around it, and a commitment and contracts and all those other things that go along with that to make that system more nimble. But that's an intriguing thought, and we do have onshore sovereign capacity as well.
Are there any other questions?
There's one just behind.
Okay.
So, Alan,
Sorry,
it was hospitalisation that you were showing in terms of 6 months versus 12 months. So that relates to severity of disease, which I think some of us were getting a little bit doubtful about the 6-month recommendation. But in terms of also ICU admissions, do you have any data on that?
I don't have data on that. We are talking to Sprint Surrey, who do ICU surveillance, to see if we can look at it in that context. But just noting that US study, which showed that the more severe disease, the higher the protection of the vaccines seem to be. So obviously a lot of possible reasons for that, but that's I would expect it to be fairly good. I think I have to say that just to draw the distinction between these are observational data to say that vaccine protection appears to wane. It's another step to say giving a vaccine every 6 months increases that protection, which we assume it probably does, but that's not actually what these data are showing, and I think that's important to note.
I mean, we always look at antibody and forget about T cells and even
Yeah.
resonant memory T cells, which are so difficult. Yeah.